Hello, everybody. Thank you so much for joining this Target webinar today. Um, Before we start, I'd just like to touch on the fact that this is new data that we're going to be presenting today. We're very happy for you to share about the webinar, but please don't share any of the information presented publicly as the data still needs to go through peer review. I can't see any of you, but I know that we should have quite a few people joining, and we're really looking forward to an informative evening with some good discussion. My name is Emily Cooper. I'm a researcher and a program manager within the Target team, and this is our 9th webinar in a series that we have done through the RCGP, where we're going to be focusing on patient perceptions of infection and antibiotic use using data from national surveys. The format for this discussion will be the same as previous webinars. Our speaker will present for around 40 to 45 minutes, and then we'll aim to have 15 to 20 minutes of discussion at the end dedicated to Q&A from our panel discussion, from what we get from the panel during the presentation. Panelists also field questions through the webinar and respond to some specific questions at the end. The chat function is disabled, so please do ask questions throughout the presentation using the Q&A function screen. You do not need to wait until the talk is ended. And if you do wish to ask questions anonymously, please tick the anonymous box before submitting your question. We'll try to answer as many questions as we can in the allocated time, but we will respond to questions that we have not been able to get to afterwards as well. The recording of this webinar will be uploaded eventually to the Target toolkit, as will the Q&A. And you will, after the webinar, you will be sent a brief survey directly to your email. So please assist by improving our webinars, filling this out, and it will also let you sign up for other upcoming webinars we have in January and March. Next slide, please. So, next slide. So I just want to highlight some of our amazing Target and RCGP colleagues who are responsible for the work that underpins the toolkit, and especially a big thank you for this webinar for the work from Emily, Kath, and Camilla, who you won't see today, but who worked very hard to develop and organize this. Next slide, please. And next, I'd like to say a big thank you to our speaker and panelists for supporting this event. I'll ask them to introduce themselves now. So please, Donna, if you'd like to start, and then we'll go through the different panelists.
Hi, everyone. My name is Donna Leckie. I'm head of the Primary Care Interventions Unit at UK Health Security Agency, and I lead on the Target programme of work as well. Thank you.
Hi everyone, I'm Linda Strattle. I'm a GP at the Village Surgery in Rotherham, and I've just developed quite an interest in antibiotics and all things antibiotic related. I'm a Target trainer, and I've helped at UKHSA on quite a few of these events before.
Hi everyone, I'm Dale Weston. I'm a behavioural scientist, principal behavioural scientist in the Behavioural Science and Insights unit at UKHSA. I'm a psychologist by background, and most of my work is around looking at barriers and facilitators to uptake of recommended behaviours and how to design and improve interventions to increase desirable behaviours, and work very closely with Donna and Diane in the field of AMR. Nice to be here.
Hi everyone, my name is Diana Shirodokwe. I'm lead pharmacist for antimicrobial resistance at UK Health Security Agency. I lead on our stewardship interventions, mostly for secondary care, and I'm also the lead for our English surveillance program for antimicrobial utilisation and resistance to our national surveillance program. Back to you, Emily.
Thank you all. So next slide, please. Just to say that this webinar theme was chosen based on feedback from the Target users that we had from last year's round of webinars. And the feedback was that people wanted a webinar focusing on patient perspectives of how common infections are managed in primary care. So through this webinar, we're hoping that participants will be better able to understand public knowledge, attitudes, and behaviors towards antibiotic use for respiratory tract infections, and that they'll be able to leverage the insights from the survey to improve patient understanding and manage expectations regarding common infections and antibiotic use. This webinar should be appropriate for medical practitioners in the primary care setting, including but not limited to GPs, nurse prescribers, practice and community pharmacists, and others who work to support antimicrobial stewardship in these groups. HSA Primary Care and Interventions Unit have carried out these public surveys since the 90s, examining public health seeking behaviors for common infections and to understand public knowledge about antibiotic use and resistance. This webinar will reveal insights from public survey data from 2019 to 2024, covering the knowledge of common infections and antibiotics, as well as what relevant health seeking behaviors. We'll also talk about resources and techniques to discuss non-prescribing options with patients, support shared decision making, self-care, and safety netting. I'll now pass over to Donna, who leads on this work.
Thank you, Emily. Sorry, I was just checking if anybody could hear me because I couldn't see my screen, but I think that's a yes. So antibiotic prescribing in the primary care setting in England was at its peak in 2014 at over 20 DDDs per 1,000 population per day. However, as you can see here, through a collective effort, we have seen a reduction in overall prescribing into 2019, where it was below 14 DDDs per 1,000 population per day. And these blue bars are the general practice settings. The COVID pandemic, however, did have a significant impact on prescribing, and it's across these years, so into 2020 and 2021, that we see the highest decrease in prescribing rates. But as we get back to normal, prescribing rates in the primary care setting are starting to increase again. And the recent SBOR report, which was published last week, and highlighted that, in fact, prescribing rates are slightly higher than the 2019 level pre-COVID. So we really need to pay attention to this and focus on this so that we don't lose all of that effort that was put into between 2014 and 2019. It is, however, well documented that public demand for antibiotics is a contributing factor in prescribing. Therefore, for the rest of this webinar, we want to share some insights into the public health seeking behaviours for respiratory tract infections and their knowledge and attitudes towards antibiotic use and resistance. As Emily mentioned, UKHSA have carried out annual surveys with the general public between 2020 and 2024. And we've asked people that the topics that we've covered include general knowledge and perceptions of antibiotics, behaviour and expectations when the public had a respiratory tract infection, and their experience with antibiotics in the previous 12 months, amongst other things. I just want to explain this slide to you because it looks a little bit busy. So these large buttons on the left-hand side show the years that the survey was carried out. So in 2020, we carried out a survey where we asked people about their behaviours between February 2019 and February 2020. So this was before the first national lockdown in England. So we call this our baseline data or our pre-COVID data. And throughout the slide deck, when I refer to 2020, this is the time period that I'm referring to, between 2019 and 2020. This survey was a face-to-face survey of just over 2,000 participants. In 2021, we repeated the survey and we asked the public about their experiences between 2020 and 2021. And this is what we call pandemic year 2. You'll notice this was a telephone survey rather than a face-to-face survey, and we interviewed over 1,500 participants here. And so on and so forth into 2024. When we asked people about their experiences between February 2023 and March 2024. So this was 2 years post the lifting of the restrictions. And this was an online and a telephone survey where we interviewed almost 5,000 participants. Now, you'll notice that because of the difference in how we've collected the data, it can be quite challenging to highlight significant differences. So I'm not going to do that. What we're going to present here is a lot of the descriptive analysis. The other thing to highlight is I will not be presenting data from across all of these years on every single slide because it would be too busy and it just wouldn't make a lot of sense. But what I will do is highlight it where there seems to be some obvious differences. So of the 4,976 participants surveyed in 2024, 71% reported having a respiratory tract infection in the previous 12 months, with the most common symptom being a cold or a cough. And this is pretty much identical to the 2020 survey data, so pre-COVID data. And as you can see from the graph, most rank the severity of these symptoms as mild to moderate. For those of you who are interested, this is a quick breakdown of the respiratory tract infections that they mentioned they had. So 59% of people stated they had a cold or runny nose, down to 8% of people stating they had an ear infection. Next, we asked participants to consider their most recent infection and ask them what did they do about it. So when we asked what actions were taken for their most recent respiratory tract infection, you can see we've split these according to self-management actions on the left and consultant actions here on the right. And consultant actions is where they have spoken to a healthcare professional or contacted NHS 111. And each of the graphs, you'll see the response based on year. So at the bottom here, we have the teal color, we have 2020 data, navy 2022 data, orange 2024 data. And what we can see is during the pandemic, the self-management actions were occurring more frequently than before the pandemic, which isn't surprising. Although these actions have reduced quite dramatically in 2024, there are still more self-caring actions in 2024 than in 2020. So, for example, the use of non-prescription treatment to alleviate symptoms increased from 35% to 55% and then back down to 47%, which was still a lot higher than the baseline of 35%. And on the right-hand side, you'll also see a reduction in those contacting their general practitioner during the COVID. So it went from 23% to 15%. But this has kind of gone back up now to baseline data. The difference that we do see is consulting other healthcare professionals. So we've seen a slight increase in consulting community pharmacists and those consulting NHS 111, and these are still slightly higher than baseline. So the public are going wider than just general practice for their advice and information. And if we look at this as a proportion, what we see is approximately 2/3 of the population self-managed, and this has remained fairly consistent across the years, and 1/3 of the population consults for the respiratory tract infection. And it's these consulters that we're going to talk about more throughout the rest of the slides. When we asked, why did you visit a community pharmacist or doctor surgery, NHS walk-in centre, etc., for your RTI, we observed that overall more people were visiting their general practice setting for RTIs as opposed to the community pharmacy setting. However, this survey was conducted not long after Pharmacy First was established, so there was about 2 months of a difference. And as we know, Pharmacy First covers many of the respiratory tract infections, so it will be interesting to see how these results change next year. But what we can see here is the main reason selected for consulting centred around at the top here, the need for advice, treatment, in the middle, worry, and at the bottom here, symptom duration and severity of the symptoms. And unsurprisingly, during the COVID pandemic, the percentage of people consulting increased significantly. As you can see these numbers on the screen. And these were the percentages reported in 2022. And in the next few slides, we want to review what patients reported their expectations were during these consultations. So we're going to start here looking at the community pharmacist. And just to clarify, we are aware that pharmacists do not prescribe antibiotics. They supply antibiotics via PGD. However, the majority of the general public do not understand the difference. Therefore, for the purposes of the survey, we stated prescribed, and that's the word that I'll use moving forward. But of those who consulted their community pharmacist with their most recent respiratory tract infection, which was around 10% of those who stated they had a respiratory tract infection. So baseline numbers here are quite small. What they expected from the consultation, shown here in the cream color, and what actually happened during the consultation is shown here in white. And although this data is interesting, there's nothing really surprising here. Throughout the pandemic, we observe an increase in expectations across the board. So you can see these cream colors across the board increasing throughout the pandemic. The slight expectation, and again, for the most part, we see pharmacists are meeting or exceeding patient expectations. The slight exception here is perhaps advice on the need for antibiotics, which we see pharmacists, the outcome was lower than the expectation. However, pre-2024 and pre-Pharmacy First, the main remit of the community pharmacist was to either direct to general practice or assess prescriptions and dispense prescribed antibiotics, not advise on whether or not the antibiotics were needed. So this is expected. What is interesting here, however, is this huge increase in the proportion of patients who stated they expected to be prescribed an antibiotic by the pharmacist. And although it's likely because of the introduction of Pharmacy First in January 24, it does not necessarily explain the increase in 2022. And this is where we saw the major increase was between 2021 and 2022. Of those who did go to the pharmacy, though, expecting to be prescribed an antibiotic, 32%, so almost a third, also expected advice about whether or not this antibiotic was needed for the illness. Moving on to the other settings. So this is when we looked at general practice, NHS walk-in centre, minor urgent care centre, minor injury centre, and GP out of hours. So these are all combined here. In a similar manner, when we asked those consulting in these settings for respiratory tract infection in the last 12 months, which was around 27% of those with an RTI, we see a similar trend to the pharmacist slide, where patient expectations increased during the COVID pandemic and are now starting to settle back to pre-pandemic levels. Looking more closely at antibiotics, patient expectation to be prescribed an antibiotic has increased. However, prescribing rates have not. What is worth noticing here is that more people expected advice on the need for antibiotics than those who received this advice. Of those who went to these settings expecting to be prescribed antibiotics, 37% had also stated that they expected advice of whether or not these antibiotics were needed. Now, regardless of expectation and outcome, over 80% of patients reported being satisfied or very satisfied with their consultation, and less than 10% were dissatisfied. So there's obviously a lot of really, really good work going on across these settings, and patients are really happy with it. So what does this all mean? Well, the prevalence of self-care is high. Even those who perceive their symptoms to be severe are self-managing some of their symptoms. Those who are consulting, however, have higher expectations than pre-pandemic, although these expectations are generally being met where appropriate. There is, however, particularly high increase in patient expectation on community pharmacists to administer antibiotics. Therefore, it's important that we continue to support community pharmacy teams with antimicrobial stewardship tools and resources. And finally, although patients may appear to want an antibiotic, the proportion of these also want advice on whether that antibiotic is needed. So it's really worth having these discussions to get to the bottom of the patient need. Next, we wanted to move on about what the public know about antibiotic use and their perceptions of antibiotics. And unfortunately, knowledge of what antibiotics should be used to treat is quite low. Whilst 80% of the public were aware that antibiotics were used to treat bacterial infections, many of these also thought they were used to treat things like inflammation, asthma, and other ailments. Just under 1/3, so 32% of the public, stated that they were aware that antibiotics were only used to treat bacterial infections. So that's quite low knowledge. Participants were further asked whether they agreed or disagreed with several statements about antibiotic use and their effectiveness for different conditions. Most respondents, about 71%, correctly stated that antibiotics do not treat the majority of cold and flu infections, and this has remained consistent since pre-pandemic data. However, for other conditions, we see that the percentage correct response has dropped. So these green bars has dropped compared to the pre-pandemic levels. But it's also worth noting that it's not that the incorrect box has increased, so they have moved from a correct to incorrect response. More people are stating that they do not know. They're stating they don't know. So these grey boxes have increased quite a bit. So there is an opportunity here to educate patients. When we look a little bit more closely at antibiotic resistance, we see that the public, for the most part, have an awareness of antibiotic resistance. So you can see here 79% of people correctly stated that many infections are becoming increasingly resistant to antibiotics. However, around half of people only about half of people are concerned about it, and this is more so in the young children, your family, and less for self. And these levels of concern have decreased since 2020 compared to now. around a fifth of the population being ambivalent. So these numbers are not at the minute. They're neither concerned or not concerned. A closer look at what the public actually know about antimicrobial resistance. So almost 90% of respondents were aware that unnecessary use of antibiotics make them become ineffective. However, knowledge was lower, so that is presented for some of the more in-depth questions around AMR, and we see a lot of the Republic responding to "I don't know." So the number is higher than the previous years, and again suggesting that more education is needed. And this is important because behavioural research has shown that those with higher knowledge exhibit more positive attitudes. And when we look at response rates split by responses of consulters versus non-consulters, you can see here that the non-consulters, so people who did not consult, gave more correct answers. So in this case, increasing patient knowledge could result in fewer unnecessary consultations. And it's also important to emphasize that patients place high trust in their healthcare professional. So across the years, for their GP, for their nurse, or for their pharmacist, we do see this high trust in healthcare professionals. So what are the implications? Well, public knowledge is low, both knowledge on what antibiotics should be used to treat an AMR, but knowledge is linked to attitudes, and there is high trust in healthcare professionals. So if possible, you can play a role in educating patients, which may lead to positive attitude changes. The Target team have developed a series of tools to help educate patients without adding to your workload. We know that there's only approximately 10 minutes in a consultation, so how can you add education on top of everything else that you do? So hopefully these tools that we've developed can help educate patients. And patient information leaflets are designed to be used during the consultation and are available in both the general practice and community pharmacy settings, and are available in several languages and as electronic versions. Our data shows that more self-care for respiratory tract, our data shows that we've presented today show more self-care for respiratory tract infections, which is a self-limiting illness should be encouraged. However, we must make sure that there are resources available to support this and to avoid any unintentional consequences of self-care. The Managing Your Common leaflet, for the eagle-eyed of you on the call will notice that these have been redesigned. They were only launched last week. So the Managing Your Common Infection for Self-Care leaflet can be used as a tool for the public and communities to increase awareness and change behaviour around antibiotic use, by increasing individuals' confidence and knowledge on how to self-care for their own infections and subsequently reducing inappropriate antibiotic use. It can be difficult having the to prescribe or not prescribe discussion with patient, and the Treating Your Infection leaflet, and this is the respiratory tract leaflet, has been developed through extensive feedback with patients and clinicians over the last 2 years. It has been reviewed and updated. It's designed to be shared with the patient and is completed with them during the consultation. Its aim is to increase the patient's confidence to self-care and to facilitate the use of backup antibiotics, but it also allows the patients to go away with something, feeling like they've been heard and listened to, and sending the consultation on a positive note. All of the leaflets are now available in HTML format and can be sent to patients via SMS through the Accurate system. And you can see in this respiratory tract infection leaflet, this is the area that we highlight most or better by section to help patients know when to reconsult if needed. There's the safety netting section. This is the area on backup prescriptions, and this is the information about antibiotics and AMR. So you can educate through this leaflet as well about antibiotic use and antimicrobial resistance. But what can you do in a short consultation to discuss management of infection with the patients? So the CHESTS acronym was developed and tested in a randomized control trial, which resulted in improved antibiotic prescribing and patient satisfaction when used by experienced GPs in the UK. As much as I'd love to talk through this, we don't have time in this webinar to go through it in detail. However, we have delivered a webinar on this previously, which is available on the RCGP website. So that's just a cheeky wee plug for you to go and view the other webinars. So do please review this for more information. These posters and videos may make a difference to patient expectations about when to expect antibiotics if used in the waiting room where patients can see them, and if they have the time to digest the information. In 2014, 25% of the general public surveyed remembered seeing the first poster, and 95% of these correctly answered some follow-up questions. Used alone without other strategies, posters will make a little difference to patients' expectations for antibiotics, but they can be used to reduce expectations and can be used as a prompt for dialogue. So you may have, for example, you could say you may have seen these posters or videos in the waiting room. The videos here were developed with patients, and evaluation of these videos has also shown to heighten awareness of antibiotics and prudent antibiotic use. The target antibiotic checklist is designed for community pharmacy staff to use with patients or carers collecting antibiotics, and the checklist should be completed by patients and pharmacists to facilitate individualized advice to the patient. So far we've covered public health seeking behaviours when they have a respiratory tract infection and public knowledge around antibiotic use and antimicrobial resistance. Next, we want to share some insights into the public experience of antibiotic use. We asked all of those who had taken any antibiotic in the past 12 months, so not just for a respiratory tract infection, but any infection, if there were any leftover capsules, liquids, or creams, and what they did with them. And as you can see here, there were some leftovers, and only a small proportion of these leftovers were being returned to the pharmacy. So you can see that here on the left. At the opposite end of the graph, here on the right, you can see that just as many people reported throwing these away, which is concerning and could have detrimental impact on the environmental impact. However, the majority of antibiotics were being kept for future use for either themselves or other family members if they became unwell. So how does this relate back to respiratory tract infections? Well, we asked those who had taken any antibiotic in the last 12 months if there were any leftovers for the following respiratory tract infections. And as we can see here in the red bars, there were quite a lot of leftovers. And the percentage of leftovers varied by condition. So there were more leftovers for some of the minor ailments like colds and flus at the top than there were for chest infections. On average, 44% of antibiotics prescribed for these conditions on the screen were leftover. And if we look at the entire population, 15% of the public that we surveyed stated that they had leftover antibiotics at home. And there's some quite serious implications of this. Leftover antibiotics may not be suitable for other family members, etc., to use. There's concerns. There's also concerns around potential allergic reactions and side effects that the person who was administered the antibiotics may not have experienced, but others might. The antibiotic itself that is prescribed may not be suitable for all infections or for another infection. And future infections may be more difficult to treat because of overuse of because the overuse of antibiotics drives the development of antibiotic resistance. So using antibiotics could contribute to antimicrobial resistance. And the other concerning thing is that the leftover antibiotics may have expired. Once the expiration date of a medicine is passed, there's no guarantee that it will be either safe or effective. But what can you do? One of the key things is when discussing the need for antibiotics, remind patients of the 9 recommended lengths of antibiotic prescriptions, and also highlight the importance of completing the courses directed by you, the healthcare professional. And you can also consider issuing a delayed or backup antibiotic prescription. Delayed and backup antibiotics prescriptions have been shown to potentially reduce patient use of antibiotics. They're useful to use if you're unsure whether immediate antibiotics are needed. And evidence has shown there's little difference in symptomatic benefit with immediate versus backup antibiotics. You can increase the patient's ability to self-manage infections, so patients feel more in control. You can potentially prevent complications and reduce reconsultations. There has been much discussion about the use of giving delayed backup antibiotic prescriptions in acute, uncomplicated infections to reduce antibiotic use and reduce patient expectations. A 2017 Cochrane review recently 2017 Cochrane review has shown the benefits of this approach without increasing complications in patients. The review of 11 studies has shown that comparing delayed versus immediate antibiotics, there was no difference in reconsultation rates. Compared to no antibiotics, delayed antibiotics led to a small reduction in how long pain, fever, and cough persisted in people with colds, and there was little difference in antibiotic adverse effects with no significant difference in complications. So there's lots of benefits to potentially issuing a delayed script. But what do the public think about this? Well, when we asked all of the participants in 2024, only 28% of the public were fully aware of what a delayed antibiotic was, and that's lower than the 2020 data, the pre-COVID data. However, 58% of all respondents felt, once they were explained, felt that it was acceptable to be offered a delayed script from their GP. And when we asked about supporting for the following conditions, urine, ear, and throat infections, you could see there was high support for a delayed script for these infections. 7%, however, in this study, in this survey, 7%, only 7% were offered a delayed script in 2024. And what did they do? Well, 31% started taking the antibiotics immediately. 42% reported, yes, they did start taking them, but they waited a few days. So you're going, well, why offer it if people are still taking it? Well, it's really important to highlight that 27%, so over a quarter of those who were offered a delayed script, did not take the antibiotics. So there is potentially opportunity here to reduce unnecessary prescribing. The Target website describes an evidence-based approach to help you in discussing backup and delayed antibiotics with patients. And again, we have a webinar covering why and how to use the backup or delayed antibiotics. You can find that here. If you are going to use delayed antibiotics, put out a huge request to please don't forget to code your treatment choice. Much of the evidence generated in these studies use read code and SNOMED codes to trawl through the data. If you haven't coded, it makes it really difficult for researchers to understand the benefit or not of any treatment. And it's also useful for you when carrying out your own audits. The SNOMED codes for delayed prescriptions are outlined in this table, and you can see these slides. These slides will be freely available later, so you don't have to quickly start looking at where these codes are. So for my last slide, I want to flag up some of the key take-home points from this presentation. The patient's reason for consulting varies. However, the main reasons center around the need for advice or treatment, worry, and symptom duration. It's not necessarily just focused on antibiotics. That being said, there is high public expectations from their healthcare professional for not only just antibiotics, but also advice into whether or not these antibiotics are needed. So it's important to remember that. Also, we're finding low public knowledge on antibiotic use in AMR. So there's a huge opportunity here to educate your patients and target some useful resources to help facilitate this. Many of the public survey report receiving antibiotics for respiratory tract infections, but approximately 44% of these don't finish the course. So do consider discussion around the need for antibiotics and link this to the duration of illness. And finally, you may want to consider issuing a delayed antibiotic. This is just an acknowledgement slide. There's a lot of people to thank, not just the people who helped carry out the research, but the panelist members that are here today. And also a huge thank you to and acknowledgement to the RCGP team who have worked really hard to help put this webinar together. And now I will hand back over to Emily. Thank you very much.
Hi, everybody. Thanks so much for that, Donna. That was very interesting. We haven't had any questions yet. So as we finish up here, if folks have questions in our chat, and we'll put them to our panel. Oh, one question. Thank you, Connor. Great. So, we have some just to say that we do have a feedback survey that will be sent out to folks at the end of the discussion. So please do feedback, and it will also provide you with an opportunity through what kind of topics you would like to hear and for the webinars. And also just a plug for the 2 other webinars that we have coming up. This one coming up, well, actually the dates are wrong, apologies. We have one coming up for navigating antimicrobial stewardship early care prescribers that will be coming up in January. And then we have one around managing recurrent UTI and reviewing long-term and repeat antibiotic therapy, and that one will be in March. So have a look at those if you're interested. And Donna, could you go to the next slide, please? So again, just the photos of our panels and their titles. And what we'll do now is we'll stop sharing the slide deck and we'll have the panelists go ahead and put their cameras on so we can see you all. Great, thanks. Okay, and the first question I'm actually going to put to Linda, if that's all right, just to kind of give a bit of a recap. Were there any, as a GP, were there any findings presented that you found resounded to what you see in practice or maybe not in some cases?
I think the leftover antibiotics bit was definitely one that I recognise, especially with patients with chronic conditions, so patients with COPD or other conditions like that. But I probably hadn't quite realised how much of those antibiotics were out there and how often people didn't complete the courses. I think it gives us more kind of awareness of having that debate about, you know, the importance of antibiotics, but also having that conversation about, well, are there other options here about like delayed prescribing as well? And also that remembering the guidelines about the 5 days. I'm definitely guilty of the automatic prescription comes up, cycling, you know, someone automatically goes to prescription. So remembering to change that every time is tricky. So I think remembering that is part of it, because patients don't actually want or need or use the full course if you do prescribe it. So I think that was a really good learning point for me and did fit with some of the things I've been aware of, but not always necessarily acted on. And yeah, I think the nice thing I think in all of it is that we still have quite a lot of kind of respect from the community. I think there's a lot of bad press out there about general practice and kind of pharmacies and all sorts, but actually it's really reassuring, I think, to hear that we are still a respected group of professionals who can really give good quality advice that patients trust and feel helps them make a good decision. And I suppose it is our opportunity, isn't it, then, to make a difference to this stuff by just a few small changes, isn't it, really? So I think those are the bits that really resounded with me.
Thank you, Linda. Great. So we have a question that's come through, and this is about public awareness campaigns to improve knowledge on antibiotic use and AMR support reducing demand for antibiotics. Focusing on healthcare professionals without addressing the public will only deliver limited impact, and the two need to go hand in hand. And this is a really excellent point. I wonder if Diane, you or Donna would like to speak to this one?
Shall I start, Donna, while you take a break from speaking? So at the moment, we are UKHSA is working through a pilot campaign. What we, as many will know, we had the Keep Antibiotics Working campaigns from 2017 until 2019, so ran for 3 years, pilot before that, and important to have that pilot, and that showed the impact that we can have when we have mass media campaign. The challenge with that obviously is the cost for mass media campaign, and then what you do find is after a year or so is you start to lose the impact that you have, and so you need to think about new ways. But what we are planning now is to have a pilot campaign, and colleagues are through our communications team and strategic comms team are working up a pilot campaign using information from part of the information from this study. And Donna, correct me if I'm wrong, I think it's last year's one, which is still broadly relevant in terms of identifying which groups we're going to work with. So starting with young children and young people, not children, young people, as well, and young adults, as well as those from minority ethnic groups as a starting point. So doing some work around that. So once we've piloted, and when we get the results for that, then we'll consider options for scale up. I do think we need to remember that there are already several resources available that healthcare professionals can use with members of the public. So it's not always through mass media campaigns need to have an impact. So I think there is that importance of the role that healthcare workers have in communicating with members of the public. Community pharmacists have a key role with that and are already doing a great job through a range of activities. And then locally and regionally, there are campaigns that run as well. And we, of course, have the eBug resources. We have the target resources and the leaflets and posters from Keep Antibiotics Working are still available. And finally, we have the Antibiotic Guardian campaign as well.
Thanks for that, Diane. And I wonder, just on the back of that, Dale, can you talk a little bit more about the usefulness of serving the public in this way and what we can learn and how does this inform practice as well as the campaigns that Diane was just talking about?
Yeah, of course I can. So in behavioral science, we take a very sort of systematic evidence-led approach to developing interventions. And when you talk about interventions, it can be anything from public campaigns through to helping to scaffold what GPs might want to say as part of their individual consultations. And the only way you can really do that is if you understand what are the factors that underlie people's decision to undertake a particular behavior, be it asking their providers for antibiotics, be it keeping antibiotics for kind of a future use or what have you. And so the very first thing, whenever we get anybody come to us with a particularly problematic behavior, the first thing we do is urge them to get data. And so seeing this kind of really large scale survey that is repeated over time is really good for a few reasons. Number one, it helps us to identify what the more problematic behaviors are. And so we can really focus our efforts into developing interventions to address those. Second one is if you measure it for long enough over time and you use standardized measures, you can start over time to track, as Donna was doing in that presentation, where there are changes and where there are shifts. And so you can start to see over time whether putting all of your resources into a particular type of behavior might be yielding or the outcome that you want, or whether it might be time to sort of focus somewhere else. So I think it's really good to see this sort of thing. More investigation of more public health issues should take this large scale approach to data collection.
Thanks for that, Dale. Another question was one raised about saying it's interested in potentially incorporating the target leaflets and hospital discharge information. Sorry, the lights are off. Going off. There we go. Post uncomplicated infections to increase patient knowledge and understanding around antibiotics infection. Despite their design for primary care, do you consider them suitable for this use? And we do get quite a lot of queries around that. Donna, do you want to respond to it? Maybe and chime in.
I can respond initially. I think it is important to highlight that the leaflets have been designed for primary use. However, this is something that does come up, as Emily said, time and time again about incorporating them into secondary care. We have been rolling out target training with our NHS regional and AMS lead colleagues, and this is something that Laura in London has brought up, and so we are going to be working with Laura with the view of speaking to secondary care consultants and identifying are the leaflets suitable for use, looking and reviewing at the evidence, and hopefully building up an evidence base to say that we can or cannot use them in secondary care, and if we can, then to make them more widely available. But I think we really need to understand the issue and understand how they would be used properly first before we can just implement them there. Dan, do you have anything you'd like to add to that?
Yes, I can. I think also one of the key points to think about is that there are quite a few leaflets within the target toolkit. So the antibiotic checklist, so when a patient has been dispensed antibiotics, I think is immediately relevant for secondary care in the context of a patient is in an outpatient setting or when they're going home. So I do think that can be used now because it's about how do you counsel a patient through the antibiotics, except of course they have parenteral IV antibiotics, then that wouldn't be relevant. But if they're getting oral antibiotics, that is ready and available to use now because and that can be used by any of the pharmacy team members who are counseling, or even the nurses as well, because it's about when a patient has been given an antibiotic, how do they take it? But I guess the ones that we will need to think about is the general understanding around antimicrobial use and perhaps what we call the respiratory tract infections or the UTI, which may not be relevant immediately within secondary care because of how ill the patients are. But having said that, if a patient comes into outpatients into A&E and they're going home, it's quite similar to them going to see their GP. So again, it can be used. So there are ways in which they can be used from now, whilst more evidence is being developed through more insights as the primary care interventions unit, whatever they develop, they always use a lot of insights before they get to the final product. So, but there are things that I think people can use now.
Thanks for that. And just a little bit of a plug, if anybody is interested in getting involved in any of the resources we develop or the research we do, please sign up for our newsletter and let us know that you'd like to get involved.
Can I just add one more thing? Sorry, I
Sure.
really want to encourage colleagues around considering that for secondary care, mainly because we know that one of the biggest gaps we have is around educating patients about their antibiotic use through secondary care. And so it gives us an opportunity for us to do something about that.
Thanks, Diane. All right, so we've had a couple of questions come through about delayed prescribing, and Linda, I'm wondering if you'd be able to respond to these. So one person is asking about ways that delayed prescription can be provided, especially if some patients don't like to come in for frequent visits or reviews. And then another is talking about concerns they have about delayed antibiotics in patients, maybe keeping them for later use and using them in the wrong issues. So if you have any thoughts that you could share, that'd be brilliant.
So I suppose just to plug the previous webinars, there's a whole webinar, isn't there, about this, which does go through the evidence behind it and how it doesn't always result in the patient taking the antibiotics. It can leave us in a bit of a tricky situation, that though, because as soon as we sign the prescription, it will then send it through to the pharmacy, and so it will count as one of our kind of prescribed antibiotics for that patient. But on the Target website, there is actually a whole section on ways to delay antibiotics. So it doesn't necessarily mean you have to write the prescription that day. So you could write the prescription that day or post-date it, and then obviously it will be one that's with the pharmacy at that point. Or you could ask the patient to contact the practice again, or provide some kind of online way for them to access it again via the practice. It does result in obviously the patient then contacting the practice again, but then it wouldn't count as one of your kind of prescription courses of antibiotics at that point. I have found that having that conversation now and opening up that, okay, well, you know, this is the things it could be, this is why we're considering not necessarily giving immediate antibiotics, does kind of open the patient's eyes a bit to the not necessarily needing it right there and then. And then it allows the patient to see that there's perhaps other ways that isn't an antibiotic right now. Because I think the difficulty in those consultations is there's often an agenda and expectation, as we've seen in the slides, for the antibiotic to be given for whatever infection it would be. So it's then having maybe just not the outright no, it gives that kind of middle ground. How you go about doing that, as I say, there's various ways you can do that, whether it's delay prescriptions or prescription but don't collect it immediately or contact back. But it actually just gives a bit of a middle ground so that perhaps you don't get the complaint, or you can end the consultation in kind of a nice kind of shared understanding way. I did it quite recently in front of a GP trainee. He'd never seen that as an option, and then he took it away to another consultation and used it. And it's sometimes modelling that or looking at ways of doing it that helps them other people do that. And it's kind of almost a snowball effect, I think, once you start offering it as an option within your practice, because then patients understand that, you know, there is other options rather than those immediate prescriptions. So it's working out in your practice how that might work for you, whether that is that you will write in the notes, discuss delay prescription, and this could be a really good option, or whether it will be, you know, you do prescribe it, but you tell the patient to not collect immediately, or you tell them to you know, have a delayed prescription, so you post-date it for another date. If you're on System 1, or I think on EMIS as well, if you have ARDENS, a lot of the antibiotic kind of performers within that do have, if you do say a fever pain score, it will suggest delaying the antibiotic prescription in that. And actually, I even show that to patients. So if I'm doing a fever pain score for tonsillitis, I get it up in front of the patient and I say, look, this is your score. This is why we're considering or not considering antibiotics. If they're in that middle ground, this is what the guidelines is telling me to do. And actually using the guideline in front of the patient can often help support your decision as well. So it gets the patient on board, that it's not just you saying, I'm not going to give antibiotics for whatever reason, it's you showing the evidence to them to kind of get them on board with it as well. So I think that kind of really helps get patients on board, and it has definitely helped in our practice with it. And it gradually spreads. As some people start doing it, more and more people get confident with it. The nurses and the receptionists get used to that being an option, and so but you just have to start somewhere.
Fantastic. Thanks, Linda. All right, so another question, I think possibly for Donna. Do you know of any areas that have successfully incentivized the use of target leaflets in primary care as part of a consultation? For instance, as an indicator on a prescribing incentive scheme. It just is, I think they've been exploring options, but they were having a difficult time.
I think the short answer to this is no. However, what many of you on the call may be aware of, and many of you may have already attended, we have been rolling out the target training across the regions of England. And part of this training is highlighting the use of the target leaflets and the target materials, etc. And we're evaluating. We know that in some areas they have embedded part of target training as part of a financial incentive scheme. And what we will do as part of the follow-up is look at and this is why the SNOMED and the READ codes are really, really important for to input these, is we will be looking at some of the data, looking at some of behaviours to see if use and uptake of the leaflets have increased, and we can do that by looking at the SNOMED codes. We can try and look at some Accurex as well, but also having surveys with the clinicians who took part in the training to see if they're telling us if they've increased use of the leaflets, etc., or not. So we're looking into it is the long answer, and the short answer is no.
Thanks, Donna. I have an interesting question. Oh, sorry, Diane. Did you want to add?
Yeah, just to add to what Donna's saying there, I think also that the colleague who's asked the question could also ask the NHS England antimicrobial stewardship lead, because they are picking up what is happening by region, and they may be aware of something as well, which is happening locally. I know that they're doing some work to understand what incentive schemes are being used over time, so they're having to think more locally around those, and also we know that antimicrobial stewardship is on the medicines optimization options list, so things might be coming up in recent times, so that's another way that colleagues can do that, and we can also take that away and maybe send it out later.
Fab, thank you. So we had one question come through. There has been, so Dale, maybe you can respond to this one. There have been public health information ads on TV about sepsis and the sticks in people's mind. The request for antibiotics are driven by fear, particularly carers for older people, both in care homes and domiciliary care. When I refuse to prescribe and give an explanation for this, I'm often not believed, and they call out of hours when I have left. When I have left, who give the antibiotics.
Yeah, this is an unfortunate but not uncommon experience across a lot of the areas that we work in. I think a lot of it comes down to the way that quite often in the past campaigns for public health interventions have been used. Quite often in the past, campaigns would attempt to elicit an emotional response, and so you're absolutely right about these kind of fear appeals. And we know from decades of research now that the fear appeals can be very effective at eliciting a response, but it might not necessarily always be the response that you want to elicit. The only real way to ensure that fear appeals are effective is that they need to be paired with really clear and concrete information about what the recommended behaviours are, how to undertake them, and why they are likely to be effective. And it's that kind of why and how that's really important there. And that's the kind of the main way that we can get around people sort of responding in a kind of a fearful and emotional way, asking for what they think. It all comes down to, it's aligned quite nicely with the stuff that Donna was presenting about knowledge and understanding. And so there isn't really a quick fix. It's not really an easy solution, but changing public perceptions of the situations in which antibiotics are likely to be useful through a variety of different means, and increasing perceptions of these recommended behaviours, not as something that you want people to do because you're trying to protect antibiotics, but getting people to do these things because this is the most effective method of addressing your particular concern. These are the most effective steps that you can take is really kind of key there. So it's about trying to help socialize to people the fact that the recommended behaviors are effective and important and the reasons why they're effective and important. I think the last thing I'd say on that is the point about calling out of hours when they've left and then give them to them. Yeah, I mean, consistency. I think what we're trying to aim for here is consistency across the system, and there needs to be consistency across the system because where messages are inconsistent and these kinds of, that then it then raises the question of, well, if you're telling me and then I call up again and they're just giving them to me. Well, did I need them or didn't I? Somebody here isn't doing the right thing. And so I think it's a bigger question, and I don't have a straightforward answer to you. But part of Target and part of all the work that we are doing is to try and increase the consistency and try and standardize the way that we talk about antibiotics and the way that we prescribe antibiotics. And I think that is really the only way forwards. But what you describe is not uncommon or unfamiliar to me.
I think I'd just add into that as well. So I had an experience of that today. Mother of a child who had presented to several GP practices and appointments with viral type symptoms, then eventually ended up in out of hours and prescribed an antibiotic, and then was coming again expecting more antibiotics 2 weeks later. So things that helped was really listening, acknowledging that the first kind of journey had not been great and that it had felt frustrating was useful. Then, as I said, getting up the scores. So I got up the fever pain score in front of the mother, showed her that the child didn't score very highly on it, then explained what that meant and why it was relevant not to go straight for the antibiotics at this second presentation, but acknowledge that it had been difficult in the previous episodes. So I think if you don't acknowledge the distress in the previous times when it's happened before, the cycle never changes, does it? And then clear safety netting. So using the Target web leaflets are really great. They have those key symptoms on them about when to seek advice. There's also some really good leaflets on the Healthier Together for children. So it's Healthier Together, it's available across the country, and they've got like the red, amber, green that fit with the nice sepsis and kind of under feverish children guidelines. So that's really nice, again, to give that, this is when you need to seek advice, this is when this is relevant, because then it gives that parent the confidence in you that you've made a considered, careful decision about the antibiotics. It's not just a write-off that it's viral and you've thought about it, but it also helps them understand at what point it's relevant for them to have those antibiotics. And the delayed prescribing can also be really useful for those who you suspect will go on and to keep on trying to find a way to get antibiotics. The other thing we find useful is follow-up. So we book in a phone call 2 days later. Say, okay, we're not going to give them now, but how about if I call you in 2 days and see how you get? Phone call will be much quicker. You already met the patient, you have to start again from scratch. And it also then just gives the patient that feeling that they've been listened to and that they have a plan and they've not just, to try and book another appointment another day. So sometimes I've found that can be quite useful as well.
Thanks, Linda. And I have one more quick question for you, if that's all right. I've seen reluctance in patients to practice for assessment of patients, then also back continue to 1 second course strategy that you found useful for this?
Again, I think you have to have a practice approach to that, really, because patients will probably doctor shop until they get what they want. And I think the trend to go towards online triage and things isn't kind towards this, really. So I suppose it's trying to go back to having a no message. Actually, we've done it with UTIs, urines that are dipped, that are dropped off and not automatically dipped and get discarded if a consultation hasn't happened. And you have to have quite a harsh line on these things. So you have to make it, everyone does the same. So if there is patients who are dropping off urine samples without now, and we have a clear sign of reception saying they go in the bin, we will not process random urine samples, the risk is too high. And I think you have to all have that message about things generally. If you have to just say no, well, we won't give you the antibiotics unless you come in. It's tricky. but you have to explain. And if you make the explanation, say, well, I make a decision, I might be missing the cause. You might actually have a different problem. I could give you resistance. I could give you an allergic reaction. I could give you diarrhea by giving you this, and it might not be the treatment you require. And if you explain, again, often I find that helps to encourage people to come in. But yes, it is tricky if people have, you know, other mental health conditions, or it's difficult for them to come to the practice. But if you keep saying that message across the board, it does usually get through. So it's consistency again.
Fantastic. Well, that's our time up, and I can't thank everybody enough for presenting and Donna and being part of the panel. We've had such a good discussion. The questions were amazing. Any questions that we didn't get to, we'll respond and then publish when we publish the presentation on the toolkit. So do, if you would like a notification when that happens, do sign up for our we have a we say it's the newsletter. It's actually just a contact list on the Target website, and you can say what you'd like information about, whether it's the newsletter, whether it's new resources or things being published, and we'll go ahead and send you a notification when that happens. But otherwise, thank you so much, everybody, and thank you everybody who's joined today. We appreciate it.